welcome to everyone. I am Sage Howard. I am the Senior Director of Clinical Integrity here at CAIO. I will take just a moment here and show everyone who we are. This is us. We are CAIO. We are a provider of ABA therapy. We provide services in the home, in the school, in the community. We have some center locations. And while we were founded many, many years ago in the East or the San Francisco Bay Area, you can see that we have grown quite a bit in the last few years. And so we have many locations across the country. And I certainly invite you to learn more about us. You can visit our website. We also have lots of webinars such as this one. You can see that we offer throughout the month, every month. I imagine there'll be some new ones for April up here soon. So go up, feel free to take a look and check out CAIO. And now without further ado, I am very, very excited to introduce to everybody our two wonderful guests today. Excuse me. First, we're very excited to be joined by Dr. Catherine Lord. She is a distinguished professor in residence in the School of Medicine at UCLA, and she is a senior research scientist in the Semel Institute for Neuroscience and Human Behavior. Dr. Lord is a practicing clinical psychologist with specialties in autism diagnosis and interventions, as well as social and communication development for autism. She has had a profound impact on autism research with her longitudinal studies of social and communicative development in autism spectrum disorders. Her commitment to autism expands past research and includes, as probably many people here know, the development of standardized diagnostic instruments for autism with colleagues from the UK and the United States. She is well known for her work in the creation of the ADOS, the Autism Diagnostic Observation Schedule, as well as the Autism Diagnostic Interview Revised, which is a parent interview. In 2019, Dr. Lord was presented with the 2019 International Society for Autism Research Lifetime Achievement Award for her outstanding commitment to autism research. So welcome to Dr. Lord. And we are also joined by my colleague, Mel Willa, who is the co-founder and the chief clinical officer at CAIO. Melissa is a board certified behavior analyst. She has been working with individuals with autism for 25 years. She obtained her bachelor's degree in elementary and special education from the State College of New York at Geneseo. She earned a master's degree in behavior disorders from Teachers College in Columbia University. And Melissa was the first BCBA ever employed by San Francisco Unified School District, where she helped the district to establish a continuum of classrooms for children with autism, preschool through secondary, and launched the district's first formal home-based ABA therapy program. She founded CAIO 16 years ago with her partner, Colin, and we are very grateful that she did. So before I pass us over to Dr. Lord to take the floor, I just want to kind of briefly set the stage to give you a little peek about what we're talking about here. In December of last year, 2021, the Lancet Commission released a comprehensive report on the future of care and clinical research in autism. The commission set out to answer the question of what can be done in the next 5 years to address the needs of autistic individuals and families worldwide. Lead author and researcher happens to be here with us today, Dr. Lord, and she will share some highlights of the commission's findings, including their proposal for a novel, modified, stepped care and personalized model of health intervention and assessment. And then after she speaks, time permitting, Melissa will have a few comments for us to discuss how the commission's findings relate to the clinical philosophy and services that we provide at CAIO. So Dr. Lord, I will give you the floor and you could go ahead and share your screen if you'd like.
Here it comes. There we go. Hi, everybody. It's very nice to be here. As you can see, this commission was a big effort by lots of people. And I'm going to go through some things quite fast that are not that important probably to you, and other things more slowly. So I just wanted you to know what this is. And basically for the commission, I don't know exactly why, but I was invited to put together this commission. Tony Charman agreed, who from the UK, agreed to co-chair it with me. And then we, with the Lancet editors, put together a group of people. We actually had 3 meetings in person before COVID. The last one was February 2020. So we just squeaked in, and including 2 conferences about international approaches to autism. And then people outlined sections. We went back and forth with revisions and reviews. We then had a formal presentation to 3 reviewers who went through it line by line and are now authors on the paper. More revisions. Lancet then changed all our syntax and made everything I said sound British. Then we had a launch in December, and it is now out online. There is going to be a hard copy that is supposed to be available sometime in spring, and I can let you know if you're interested. This was paid for. None of us were paid for our time at all. This was just voluntary, but various autism advocacy organizations and not-for-profit family foundations, and then UCLA also paid for basically transportation when we were going to conferences. And I am working on a plain language version, chugging away on this thing. It's much harder than I thought it would be, but that will be available sometime, hopefully in the next month. I'm not sure how, but again, we can let you know. So the goal of this commission was to be international and to be cross-disciplinary. So we had people from 6 continents, 13 different disciplines, and we had 30 people, including people with autism and parents of autistic people. And our first point is just urgency, that we really don't want to just wait for biology to solve autism, because biology is incredibly important, but it's clear that we're not going to have immediate miracle cures or treatments from biology in the next 5 to 10 years. And we need to spend more time thinking about the people that are alive in this world and their families and what we can do. I think within that point is the idea that there is a lot of evidence and scientific data that is ready to be used. And much of it isn't perfect, but we can still make a lot of sense from it. But we need to be direct, and this is what Sage said already, about figuring out what works, with whom, when, and with what intensity. And that we really often don't know. We really don't know if 1 hour a week of speech therapy is sufficient, and for whom, or 20 hours a week of ABA. I think we recognize that autism is a neurobiological condition and that basic and translational science is important. If they weren't doing it, we would push for money for that. But by far more money in terms of grants across the world really has gone into animal models and single cell studies and genetics than looking at the actual people. And we don't think that that's going to be solved by biomedical solutions. People in general, not just autistic people, are too complicated to just have simple solutions. So our committee decided we were going to focus on just things that could have some effect in the next 5 years. And this could be an effect on the lives of autistic people or their families or both, with a primary emphasis on mental health, but some attention to physical health because it makes a difference. I think I'm preaching to the choir here, but I think we all know that autism manifests itself differently between individuals. Some autistic people are incredibly articulate and verbal and arguing to be part of research. Other people need support all day throughout their lives, and most people fall in between. We also know that it manifests differently within individuals across the lifespan. It's a developmental condition. So something that you would do with a 3-year-old is not going to be appropriate for a 25-year-old. And that autistic people require different things at different points in their lives. To address this, we coined the term profound autism, which has turned out to be controversial, particularly for the self-advocates. But the idea is that often, particularly in the media, what gets represented are people with autism who are just kind of quirky and have mild problems in daily living. And that those people do exist and are important. But in addition, there is a subset of people who really need daily supervision, who cannot speak for themselves and don't end up advocating for themselves, and who need extensive care throughout their lives. And they can be pushed aside sometimes when we get caught up in arguments, for example, for full inclusion or paid employment for everybody, which is important, but again, not for everybody. Sort of the converse of that, though, is we do want to acknowledge that autistic people can have real strengths, and that we want to do a better job of building on those strengths and making sure people can use those, and valuing autism and neurodiversity for its contribution. So this is something I'm going to skid through, but if you'd like to see it, it's in the paper, or I can send Sage and Melissa the slides. But just the idea that you start out with kids that are biologically different. That's over on the left-hand side, and that probably begins prenatally. By the time they're born and in the first few years of life, those kids have different social and communicative understandings. They don't necessarily understand social behavior the way other people do, and they respond to things in a different way. They also may be afraid sometimes because they don't understand, and they have different experiences because of the way they behave. And these are things, some of these things we can change. We can change their experiences, and we can reduce their anxiety. We can help with ADHD. So those are things that develop along the way, which result in many people with autism having limited educational achievement, difficulties in very ordinary social situations, and continued mental health concerns. And then if you move all the way over to the right, where we're left is a population where some people can do extraordinarily well, but they're not the majority. Even of bright autistic people, most people are not living up to their potential and continue to have mental health problems, do not make as much money, or are not as independent as they would like to be and we would like them to be, and don't get the training that they could benefit from. And in addition, there is the group with profound autism that don't even get into that last chart. So we have tons of evidence, it's just that it's imperfect. And basically, these are research projects. This is from a meta-analysis by Sandbank and colleagues, so you can look it up if you want. And where you see the line on the right, any dot to the right of the line means that people improved. Most of this research is with very young children, but we have a lot of research that shows relatively small improvements. And there are also areas like for teach where we really don't have very much research. And it's hard to believe that it has no effect, but that's when you put the research together, that's what it looked like. The other issue is that people have very strong opinions. And I think I'm sort of in the middle, but obviously it's easy for me to say about that there are lots of behavioral studies that show change, but those studies didn't have the kind of controls that you would have in an ordinary medical study with a random assignment of people. So some people who get treatment and some people who don't, not by choice, but by random, and blindedness. That is someone testing the outcome who doesn't know what treatment kids are in. And you can see here where there's little dot with little asterisks. These are the randomized controlled trials. And generally the effects are smaller when you have a randomized trial. We also, on the whole, don't have medications to treat autism at all, but we have some medications, for example, for ADHD and autism that seem to help. So our plea is for research on a much larger scale, coordinated across arms of the government and services that find results that are meaningful on an individual level. So it doesn't help us to know that all autistic kids get better in treatment A compared to nothing. I mean, it's good to know that, but we need to know, what about treatment A versus treatment B, or treatment A as a high dose and treatment A at a low dose? And we also need to know who are these kids that are benefiting? Because generally speaking, in most studies, about 50% of kids get better. 50% don't. What about those kids? We also need to know more about culturally appropriate adaptations across the globe. Almost all the research has been done on white, American, Canadian, British, European kids of generally upper middle class families with a lot of support. And that may not, the things that we find may be different for families that are struggling just to get basic resources. And we need to attend to strengths more. So we really feel like there's a lot of information that we can put together and move forward, but moving forward is going to require working together because of the heterogeneity of autism. If we're going to really look at what works for whom, we have to have different people in different groups and enough of them to test them. So we really wanted to also see what we could do now. And that's where we came up with this idea of a stepped care, personalized health model. And it's the idea that since autism can be so different among people and across time, we need to personalize what we offer. The other important thing there is that stepped care was really originally proposed for low resource countries. And it was financial. It was like, what is the cheapest thing that we could do to treat people, for example, with depression? Let's do the cheapest thing first and see if it works. Only then, if it doesn't work, let's do the next cheapest thing. And this is financially fine, but we felt like it's very important when you have steps to consider not just the money, but also the burden on the family and the preference of the family and the people with autism. And so if the cheapest thing is to tell you to drive 3 hours and get something once a month, but that is very difficult for you, that shouldn't be considered the first step. The other thing is that there is precision medicine, which many of us are interested in, but precision medicine really has to do with characterizing your tumors, not you as a person. It's saying, what kind of cancer do you have? Where did that tumor come from? And I'm going to create a medication or a treatment that gets at that tumor. And this is very different because autism is not a disease. It's not a tumor. These are whole people. And so various things make a difference that are not the same as treating, for example, cancer. So we have proposed this model of steps where you consider both what are the priorities for a family, priorities for a child or an adult, and then you personalize that step based on the preferences, needs, strengths, and challenges of that family. I think the first important thing here is if you're going to do that, you need to know about these things. And often we don't even ask. Parents tell us, I don't want to do that, or I'd love to do that, but we don't start with, well, what do you think? And how hard will it be for you to get to do this? We also have to remember that more and more, many of us are being asked to see and treat adults and adolescents. And many of our models are really based on preschool children or early school age. So this is the scheme for the stepped care personalized health. And the idea is that I'll first show you this whole thing, and then I'll show you some examples where we can look at it more carefully. You start on the left and you try to figure out what is most important to deal with for this child and this family. And you define goals of treatment. And there, I think we need to be careful that in most cases, our interventions do not cause recovery, they cause improvement. And that's fair because I certainly know people who have really moved out of autism, but they moved at one little step at a time, improving. We then go over to the next two columns, which are what are the factors that are going to affect this treatment is going to work. And rather than just blindly say, you know, everybody needs 30 hours a week of ABA or everyone needs CBT, we're going to say, what are the issues for this particular child? Are there safety issues? Are we worried about this child wandering or, you know, hurting himself by banging his head? How old is this child? What is the developmental status? If you have a 10-year-old functioning at a 3-year-old level, you are going to do different things. What is the family's preference and the individual's preference? Is this an adolescent who does not want medication? How severe are the symptoms? And how do they affect the child's daily living? What are cognitive and language skills like? Where do things happen? If they're happening at school and we're trying to work at it at home, that may not make the greatest sense. And then not forgetting strengths and interests. And I think what's hard here is many of us do this informally, but we don't necessarily do all of these things for everybody. And I think particularly when we divide up the world into, for example, BCBAs and psychologists, we sometimes don't know. People go into treatment without knowing, does this child have a significant intellectual disability? Or is this child's receptive language really poor because he doesn't understand? We then need to move to family factors. What are their preferences? Are they really able to participate in the treatment or not? Some families really can't, and other families are right on the ball. What is their acceptance? Do they have grandparents in the background who are saying nothing is wrong with your child? And what are the life events and risks? You know, we can't ignore it if someone is getting divorced or someone is having a new baby. And only then with that information, we go into considering the accessibility and cost of different treatments. So there may be things that are highly accessible for a family that aren't necessarily cheaper, like home-based care, which may be very much preferable for some families and not for others. There may be many families that want services after hours or on weekends, which is tough on our providers, but a reality, or at school. And then we now have telehealth, where I think you can do a lot, but there's also certain things you can't do. We then look at, there are things that are a little bit less accessible or more expensive, and that might mean travel to a local center. It might mean groups, which for some autistic people are wonderful and for others are not, and medication, which does need to be monitored. And then things that require a high investment of family time, or something like inpatient services will make a difference, or very intensive hours. So this is just an example, and I think this covered. So if we had a minimally verbal child in a lower to middle income country, so say this child is in India, we would need to know, do people think this child has autism? What do they think is the priority for the family? This child is not talking yet. And what is our treatment goal? And maybe our treatment goal is, let's look next at the factors that affect the likelihood of treatment success. So if this child, for example, is quite intellectually disabled, maybe the child doesn't do anything above a 2-year-old level, we're going to have to deal with safety issues by making him safe, by preventing him from getting out of wherever he is. That is going to be different than an older child where you're trying to institute rules that they understand. We need to know that. We need to know if the child understands any language before we start teaching him things that are over his head. And in this case, for example, the child is still at home, and we may want to see if we can find school services for him. Maybe this is a family that works night and day, and the child is primarily taken care of by grandparents. That is going to be different in terms of how we plan our strategies. And it may be that we're going to do home-based treatment, but maybe with a grandmother, or maybe try to see the family after hours of school so they're not missing work. This would be quite different if we take a 15-year-old girl who is overwhelmed with social anxiety in the United States. So for her, one of the main issues is anxiety and getting her out of home. So She is quite bright. We're not worried about her academic skills, except that she's terrible in math, and that makes things harder. She doesn't have severe symptoms of autism, but she also is not very good, for example, with hygiene, which does not help her social life. And she's smart enough to understand this. And some issues happen at school, but she's having a lot of problems interacting with her parents, and then also just getting out of the house. What can she do, and with whom? This family comes in wanting medication. They want an anxiety drug to make her happier. So we don't have to give her the drug necessarily, but we definitely need to listen to them and what do they want. On the other hand, the mother spends a lot of time with her daughter and would love to know what she could do better and how could she include other kids. And this family has the resources so that they could travel to a group. The parents could afford to hire somebody to help them, and the girl could be a part of groups supervised by someone else. So that may be our priority. And it turns out the psychiatrist thinks that medication might help her with anxiety, but we don't want her to just walk out with a pill. So I think that's the idea coming forth. So I think we want to remember that kids spend, at least in high-income countries, kids spend most of their day in school during the school year. But schools are often underfunded and may not have personnel to help. In lower middle-class countries, kids may not even go to school. So that is a whole other fight. And one of the things that we want to support in the countries that were represented in our commission is the need to be sure there is appropriate schooling for these kids. I mean, we don't even necessarily have appropriate schooling for all the kids in LA. We also need to build workforce capacity. And the reality is most professional care offered to autistic kids is not done by BCBAs or clinical psychologists. It's done with people with less training. So we need to figure out how to better train them. And then the way the crazy reimbursement system works in the United States, the better trained you are, the more money you bring in. So it's easier to charge for you. And so, I mean, I think that's something Kaio has worked on, is how do you have a workforce that doesn't cost an extraordinary amount of money, but provides sufficient task sharing between the people, the BCBAs and the technicians, and also supervision. If we need to have step care, if we're going to have step care and personalized health, we also need to know more about what's going to work for whom. We need to know if there are some kids who are just fine if they get 10 hours a week of ABA plus preschool, and other kids who need much more. We need to know which interventions are effective for whom, when, and what intensity. For example, teaching a 10-year-old joint attention is probably not terribly useful, whereas teaching a 2-year-old joint attention who hasn't figured out how to look where other people are pointing can be very valuable. This means that we have to have knowledge about this. And a really good example of where things can go awry is that the CMS, which is the organization that controls Social Security and Medi-Cal and Medicare, announced a few months ago that they were going to not fund telehealth, at least for a first visit, which is crazy because one of the things we found out is we can do a lot by telehealth, but we also need to see people in person. But to be told we can't do it, particularly for the people in Medi-Cal, who are the people who have the lowest resources, made no sense. They didn't have this mandate for Medicare because there's a very strong constituency of elderly people who argue, I want telehealth. But there isn't a strong constituency of people with Medi-Cal for kids with severe disabilities, and they didn't argue. The good and bad news is Omicron hit and CMS took away the mandate. But the point is that we can just wipe out opportunities for families without thinking, particularly through healthcare. And we need to figure out what's financially feasible. I think giving everybody 40 hours a week of ABA and 2 hours a week of CBT is probably more than they need in many cases, but some cases need it, and we need to figure out how do we do it. These are recommendations, particularly from people from non-high income countries, where some countries don't even keep track of autism, so they don't even know how often it occurs. We also, in the healthcare system, we can't bill for talking to someone else. So if I talk to someone at CAIO who is seeing my patient, I can't bill for this unless I make them sit there and bill it for family therapy. We also need focused research strategies, and this will involve across centers. We need to be able to use the strength, of people like at CAIO and other organized treatment centers to give us information about what works for whom. And we need to make sure that people aren't getting lost. Again, the issue of underserved, underrepresented groups, which include people with profound autism, but also includes females, includes minority, ethnic, and racial groups, anybody who is socially disadvantaged or from a rural community, or kids with severe occurring conditions, because nobody wants to see them. So I think I already talked about this with profound autism, but again, I think these are just repeating the things that I've said already. And then the last point, I think, is I really like this slide, the figure, even though it's a little bit hard to follow, but it's the idea that if we have better opportunities, as that red line goes up, more people can reach their potential. And it's true for everybody, both people with low cognitive ability, people who have some disabilities or some, but are making progress, and people that are very high IQ. And the idea is if we pull up that ceiling and help people do the things they're capable of doing, we can make a difference. And we could do this in the next 5 years if we work together. So let me stop. And Melissa, you're on.
Thanks, Dr. Lord. Sage, any questions from you for Dr. Lord before I talk about CAIO?
First of all, thank you for that. I thought that was it was exciting to see. I think a lot of the things that you were talking about are so topical in that we have started talking about, and especially your slide that was almost like how to really do this really comprehensive assessment. And we say we're doing a really comprehensive assessment, but I think we have realized there's pieces, especially around working with the patient themselves and really getting a 360 view. And as we've been talking about, I'm curious, the way that you were even laying that out in that sort of path, do you imagine there almost being a tool that could help somebody make sure that they are getting the feedback and the input from all the sources that it felt like there was this really nice path you were showing. And I almost wanted to take a screenshot to say, I hope we're following that path.
I think if there was a written tool, it would be so long and you would have so many little pieces going off in different directions. But I think you could, take it certainly within CAIO and within an agency and say, all right, do I have this information? Over the years, I've been doing this for a long time, and we've sort of adapted various things, like a questionnaire we send out to families before we start that asks them, what do you want from us? And also, what do you think the biggest problems are? And what do you think your child's strengths are? And then tell me about your day and anything that's worrying you. Now, that's a little bit different for you guys, but I think you can do something like that that directly addresses, what would people want their supervisor to know? What would they want their the people actually working with their kids to know? And people will say things in writing. Some people will write pages and some people will write notes. but they'll say things that sometimes they won't tell you. They won't tell you that, in fact, when you're coming to the house, it raises everybody's tension level, or they're spending hours cleaning, or just, my mother hates you and she's here behind me saying, there's nothing wrong, there's nothing wrong, there's nothing wrong. So I think that, those are all bad things, but people will tell you more. So that might be a way to start. And it doesn't take that much time. And I think even the 15 minutes that it takes to read that sometimes can change your perception of what are you doing and what should be important here. And I spend a lot of time telling families, look, you've got this great BCBA, use them. Like, tell them you're worried about this. Don't tell me, tell them, because they can help you, even if if you don't feel like it's what they're doing, they can do it.
I think that just your whole conversation, all those slides really leads nicely into, I was really happy to hear a lot of the comments that you made that were like, we really need to know what is the right amount of treatment for each of these kids and not assume that it's the same or that more is always going to be better. And I think it leads really nicely into, Melissa, maybe you can talk a little bit about some of the work that Kaio has done related to making sure that we're not just saying, you have autism, it's probably better to give you as much treatment as we can.
Sure, I'm happy to talk about that a little bit. Dr. Lord was talking about a stepped care approach. And at Kaio, when we look at dosage for our patients, we look at factors at the individual level and the family level that would lead a clinician to believe that they require a comprehensive program, which is a larger number of hours, 25, 30 plus hours a week, or a focused program, which is in that 10 to 25 hour range. And so we're really looking at those individual factors and then watching them over time. So we don't look at, a dosage as being static for several years. We would look at how does the patient respond to treatment at the 6-month intervals, and then we adjust accordingly. So, is it the right amount? Should it be lower? Should it be higher? But we certainly find that there is a lot of variation in terms of the children that we serve and the adults that we serve, in terms of the amount of hours that equates to optimal progress for those patients. And so we know we don't employ a blanket approach where every patient's receiving the same amount of therapy.
And one thing that I thought was really, and actually I may end up passing it back to Dr. Lord for a second, but I think it fits really nicely with stuff that we've talked about, is one of the things that you had said that's really important to do is define the goal of treatment kind of at the beginning of treatment. And I'm curious, a couple of things. First of all, one conversation that we've had, which I think you highlighted in there, is like the goal of treatment may not always be to, have this person become an individual, totally independently functioning patient. And I think one thing that we see is, what are your thoughts kind of on adjusting your goal as you go along? And, you may start thinking like, this is what we're working towards. And is there a point at which you say we now need to kind of reevaluate what the purpose of this treatment is?
Yeah, I think that's really, really important, because I think when we start with little kids, often the goal is to get them to communicate. And we really are assuming they're going to be, someday they'll be fluent speakers, but we want them to communicate. We want them to play. We want them to do the things that lead toward communication and thinking and organizing themselves, as well as sort of daily living. I think it isn't that older kids who have not learned to talk very well can't communicate, but I think, after a certain point, and I think that's partly where we're looking at the concept of profound autism, but it's true for other kids as well. After a certain point, the chances of kids blooming into fluent speakers becomes very slim. And then our goals are different, because I think we're thinking about how can they communicate the things that they need to communicate, or we want them to communicate, that are important. And that could be from any way. It's not necessarily a system, like PECs or signs, or it could be all kinds of things, but you could work on each of those. I also think we probably are too slow in switching gears, and that for kids that aren't going to be independent, to think about what are things they can do that they actually enjoy, what are things that they can do that then someone doesn't have to be doing for them, particularly physical things. So it may be more important to have them brush their own teeth, or take a shower by themselves than sorting something, or matching pictures, or doing some of the things that we all do, because those are interesting activities. And if they love the alphabet and they love puzzles, fine, it's good to go with that. But then we need to teach them to go get the puzzle by themselves, and be able to do it and put it away. Or we need to teach them to go get somebody to play basketball with them, and make sure there is somebody there to do it. So I think that is really important. And I think it's hard for all of us. I mean, I've been doing this a long time, so I've seen a lot of kids grow up, and it's just like, when do you shift from the sort of standard all out, we really want you to talk? It's also not that these kids don't learn anything. I think that's the important thing. It's not that they can't learn, but it's going to be slow. And so we need to prioritize what is important for them. And if we think about them 5 years down the line, knowing one more word, or the name of one more zoo animal is probably less important than being able to make a sandwich, or make a sandwich without destroying the kitchen in the way that most, boys would destroy the kitchen, or, again, take a shower so no one is physically having to walk someone through something.
Yeah. And I think, Melissa, maybe, I know we only have a few more minutes, but that sort of, lends itself to that idea of really making sure that you are providing really personalized care, and making sure that it's not just, this is the path we've put you on, and now we're kind of going to stick with it. And I don't know if you want to talk just in our last few minutes about how CAIO thinks about that sort of individualized care.
Sure, I'd love to. This is something that I'm certainly passionate about, and that our BCBAs at CAIO are really passionate about. At CAIO, we use what we call a child-centric approach to therapy. And this stems somewhat from the person-centered movement for treatment, which is using a thoughtful, compassionate approach where a patient's needs and wants are at the center of treatment. And so that starts with conversations with the family during the assessment process about what is meaningful to them, trying to get the patient as much involved as possible as well in terms of what is important to that child. But then we go a step further. And what we do next, which relates to what the Lancet Commission is talking about with this personalized system of care, it also for us stems from some work that the Kegels, Bob and Lynn Kegel, have done in regards to their pivotal response treatment model, where we're really looking to create sessions that motivate and excite the child, because we find that when the child is optimally engaged, excited, happy, then more learning takes place. And so the way that we approach this is by embedding reinforcement strategies into the therapy activities themselves. And so when you look at sort of historical traditional models of ABA, it may conjure up images of an adult leading sessions and doling out M&Ms to a child as they get correct responses for putting together the puzzle or whatnot. And with this personalized approach, child-centric approach, we're looking at what is the child's unique special interest and how can we create activities around those. Let me just give a couple of examples to help sort of provide some imagery. Let's say we have a 4-year-old that's really interested in astronauts and outer space exploration. We're not going to teach them how to imitate random actions with objects that are meaningless to them. We might take their toy space shuttle and model doing different actions with that space shuttle. We might pretend that a block is a space shuttle and have astronauts boarding the block, the space shuttle. We might put a blanket down on the floor and pretend that that blanket is the space shuttle, and the child practices buckling their seatbelt. And there's a ton of, the child needs to work on communication skills and social skills. There's so much language modeling and building that can happen during these personalized activities. Just in that particular example alone, you can think about the therapist may be asking the child, is everyone buckled in? Are we ready for takeoff? Answering those questions, counting down, making requests like take off or faster. I mean, this makes the learning process so much more engaging and exciting for the child. For those folks listening who have older kiddos, I'll give an example of a tween. So imagine you have a 12-year-old or a 13-year-old who's interested in Minecraft, and we're working on more daily living skills with this individual. And if we are working on trying to teach how to fold clothes and put those clothes away, maybe we'll use a Minecraft shaped character for the cardboard insert that we use to help initially with folding those shirts. Maybe we'll place a Minecraft character visual cue on each drawer, a character wearing socks on the sock drawer, a Minecraft carrier with a shirt highlighted on the shirt drawer. And maybe if it's a child of that age who's quite vocal verbal, and we're working on social skills with that child, maybe we will look to pair that child in groups with a couple of peers who are also extremely passionate about Minecraft, and then facilitate a conversation with those kids on game strategy. So those are just a few examples of how we really look to personalize care for our patients.
Thank you, Melissa. I know we're at time, so I'm guessing that people have to hop off, but I hope that everybody found this informative. Dr. Lord, I personally am looking forward to, I hope there is a call to action. I know that you mentioned we need everybody's help to kind of start to gather this research and be able to look at all of these different patients that everybody is serving. And we're certainly ready to help get that into people's hands so we can get these important questions answered.
Great, thanks. Nice.
Thank you, everyone. I hope everyone has a great day.
Thanks, everyone.